Treating patients with primary sclerosing cholangitis and ulcerative colitis with an antibiotic is clearly a paradigm shift.
I have patients who would absolutely give up anything to attend their appointments and continue being on this drug. It's life-changing for them.
During the last 10 years, my focus is on the gastrointestinal microbiome as an important factor for the manifestation of a number of highly prevalent diseases. And what we are working on, and this is one of my colleagues, Dr. Shah's PhD, to look at the microbiome which colonizes permanently the small intestine. Therefore, interactions between these microbes, the immune system, and how this influences health and disease. This is one of the core areas of research. How did I identify primary sclerosing cholangitis as an important research field? One of my younger colleagues dragged me to a patient, and she was completely fascinated by a response to antibiotic therapy. This was a young patient who had this PSC, primary sclerosing cholangitis, and this patient typically also have ulcerative colitis. And this patient was, for other reasons, treated with an antibiotic, and the liver disease improved. And I have to admit, I could not believe that this patient had an ulcerative colitis because the mucosa looked completely normal. And this was essentially the starting point when we looked at the potential effect of antimicrobial therapy in patients with PSC.
PSC is a very unique disease, and the uniqueness is the interaction between the gut and the liver. PSC is associated with inflammatory bowel disease in 80% of the cases, which is a very, very unique association. We know vancomycin is effective, or antimicrobial therapy is likely effective, I would say, in this condition, but how it acts would be an area to explore. Previously, there has been no research done exploring the role of mucosa-associated microbiome or the microbiome lining the gastrointestinal tract in this condition.
In this research project, I'm particularly interested in looking at the effect the novel treatment has on the lining of the large bowel or the colon. What we've seen is in certain patients who are treated with this novel therapy, the inflammation in the large bowel and the liver both reduce significantly, and therefore hopefully the progression of the disease is slowed or even reversed. The theory is if we can control the inflammation both in the large bowel or the colon and in the liver, we'll be able to prevent the progression to liver failure and progression onto either liver cancer or bowel cancer.
I think research is important when it makes a difference to our patients. And here we have young patients. They are between 20 and 40. They suddenly have abnormal liver function tests, they get a proper diagnostic workup, and after this, within 10, 15, 20 years, they either require a liver transplant or they are simply dead because there's no treatment other than liver transplants that expands the life expectancy. Therefore, having a treatment which controls disease is a great benefit to patients and our society. Treating patients with primary sclerosing cholangitis and ulcerative colitis with an antibiotic is clearly a paradigm shift. This is a very, very rare disease. Therefore, if we want to study this in a reasonable sized population, we need to engage all clinicians who treat these patients in Queensland and probably in Australia. And this is why we set up a study network here in Queensland. Patients anywhere in Queensland essentially can be involved, recruited, because we have from Cairns to Brisbane many centers and very committed investigators who are prepared to help us. Science, medicine has become increasingly complex. I mean, we're clinicians, we try to find the best possible treatment for patients, but we need to be open-minded to incorporate what our basic scientists develop and what our basic scientists can offer. And here in this field, our microbiologist, Professor Mark Morrison, is one of the world experts in culturing this bacteria. And what we expect, while we at the moment can offer antibiotic therapy, we plan to have more targeted interventions, be it specific diets or specific molecules, which then can modify the microbiome that these patients actually can be cured. Why we do this here at the PA hospital is the availability of really high-end transplant hepatology and transplant medicine. These patients can progress to advanced liver disease and may require liver transplant. And therefore it's good to have these treatment capabilities at our fingertips if needed. We are about to start and set up all the mechanics to recruit patients, and we expect that we can start recruitment within the next 3-4 months. We designed it as a crossover trial, therefore every patient will receive active therapy. Therefore it will not be that we have a placebo arm who will not get anything, and we will identify the patients who will respond to the active medication.
Having seen the benefits of this particular treatment on individual patients, we now obtain this drug from the hospital pharmacy via special approval, and this has worked magically for them. And attempts to wean them off or stop the drug results in a flare, and we have to restart the treatment. I have patients who would absolutely give up anything to attend their appointments and continue being on this drug. It's life-changing for them.